welcome to the EAU podcasts. In this episode, UROONCO Kidney Cancer Chief Editor Dr. Mir talks to Dr. Bianchi on RCC with venous thrombosis, optimal imaging for surgical planning, and imaging-guided surgery.
Welcome to a new episode on the UROONCO Kidney Cancer platform. We are here in EMUC25 having a wonderful time and enjoying the multidisciplinary discussions. We are here with Professor Bianchi from Department of Urology in the University of Bologna. He's an associate professor and his main area of expertise is prostate and kidney cancer, minimally invasive. He's done lots of research on partial nephrectomy, and he has presented a very interesting topic at EMUC that is about thrombectomy during MIS approaches. Welcome, Professor Bianchi. We are happy to have you here. Would you tell us a little bit of a small summary of what did you speak about? What were the highlights of your talk?
Good morning, everybody. Thank you, Carmen, for the kind invitation. So yesterday we have a very nice talk about venous thrombosis in renal cancer, and especially focus on imaging, preoperative imaging and intraoperative imaging, how to predict the level of thrombosis, both in the renal vein and the IVC. We have focused mainly on preoperative imaging because we know that most patient comes with a CT scan for diagnostic and staging, but maybe CT scan is not enough to define the level of thrombosis, especially in the IVC. So the MRI still is then the best tool we have to define the level of thrombosis, especially for level 2 to 3 and especially the 4 levels. And also define the IVC wall invasion. That is a quite important point to define before surgery, to plan a proper surgery, and the IVC complete occlusion. Then we focus on a different approach for IVC thrombosis, speaking about open and also robotic approach. The message I would like to stress is that it's a very complex surgery and should be referred to referral center, especially for level 3 to 4 thrombosis. That, of course, is most challenging, and most surgeons perform with an open approach because you need, of course, also a multidisciplinary team like a cardiothoracic surgeons for level 4 thrombosis.
Yeah, and finding cardiothoracic surgeons that are keen in robotics is not that common, at least in Europe.
Yeah, it is. There are some centers that are skilled with a robotic approach, and most of these cases are level 1 to 2, and I think it's called feasible to perform. And what I would like to say is the plan for right side and the left side, because the level of thrombosis is the key. For example, on the left side is more challenging because if we have a thrombosis distal to the Hesmay artery, we can perform nephrectomy with thrombectomy without reposition the patient.
No redocking.
Yeah, without no redocking. Otherwise, if we have thrombosis proximal to the IVC, so proximal after on SMA or level 1 to 2 thrombosis, we need to perform first the caval thrombectomy to remove the clamp the cava, remove the thrombus, and then
like a right side.
And on the right side, and then change the position of the patient and perform nephrectomy on the left side. The other question is, what kind of images can we use in intraoperative? This is fine for open, but also more important for robotic because we don't have the active feedback to taste the thrombus. So, in my opinion, the most useful is the ultrasound. That could be standard ultrasound to identify the thrombus, to identify also the caval infiltration. Using contrast and ultrasound during surgery, we can predict the presence of caval infiltration and predict the need of complex vascular surgery, removing part of the caval.
How do you do the contrast ultrasound?
By intravenous injection, and then look at the enhancement, both of the thrombus.
Use the regular ultrasound that we use for partial?
Use for partial,
And you apply it to the wall while the...
you see
ultrasound.
like a interactive IVC wall and enhancement both of the wall and both of the thrombus. That means that could be infiltrated. And usually if there is more than 50% of the wall infiltrated, you need to complex vascular, maybe ask for a vascular surgery for a caval patch or caval substitution in case of complete occlusion.
But would it be done by the urologist, the ultrasound, or they have a consult?
You can done by yourself, but of course you need to be trained by radiologist first.
Not easy.
Yeah, we had some experience with focal therapy, and we learn about how to use ultrasound and then contrast ultrasound with focal in the prostate. So we had some kind of experience, and maybe in the future there is some work, for example, from Porpiglia in Turin. They perform 3D models using a reconstruction of the kidney with a thrombus inside the vena cava, and they use augmented reality to overlap the imaging the robot to identify the levels. Yeah, superimpose the level of thrombus and also where to place the clamp and properly clamp the cava in the infravenal cava. And there is an interesting work published in American Journal of Urology about a printed model of kidney cancer with a thrombus to perform a simulation by open surgery, what is the most and the step-by-step procedure to avoid losing time, yet pre-plan before surgery, not to lose time during clamping and to reduce complication.
How about any AI tools that can help with this prediction of the wall imaging or improving the MRI?
There are some tools about radiomics based on CT scan, but especially MRI, and that can predict the caval infiltration. Right now, radiologists usually use 3 parameters that are not radiomic spaces: the anterior-posterior diameter of the vena cava, the complete occlusion of the vena cava, and the diameter of the renal vein at the renal ostium, just for a prediction of infiltration. There are some work also about FDG PET to predict infiltration, but there is not so good as MRI did.
Okay. How about from your side, can you give us some tips when you go and approach like a level 1, level 2? Do you have any specific steps that help you improve your outcomes? Can you give us some feedback on how to start doing this process, how to have a step onboarding on this complex procedure?
Yeah, it is a complex procedure, and personally, I think case with IVC thrombosis should be centralized. And if you will start for robotic approach, you need to, of course, a lot of experience with advanced cancer disease performed by robotics. You should be trained, and of course, multiple imaging is essential to a proper planning. So use CT scan, use MRI, use ultrasound, and if it's available, also 3D models, because you should arrive at surgery well prepared for what could happen. And what I suggest to start with level 1, at least 2 thrombosis, because in my opinion, level 3 to 4 are very complex and performed by the robotic. Okay, it's feasible, but you need very, very experienced surgeon, but also open surgeon with open background, because it's if some complication, bleeding complication, major complication happens, you need to know what to do and convert immediately the patient.
Right. And no, I was talking more about it from your perspective. Do you have like any specific tricks? Like, do you go directly to the artery? Will you use like some tourniquets instead of clamps? Like some, specific things that might help people?
Yeah, usually we just jump to the hilum. So first ligation of the artery, that's reducing the inflow of the kidney. And sometimes you can also have a reduction of the thrombus level, especially for level 3 to level 2. Could happen when the inflow in the vena cava reduce, and then conventional clamp using tourniquet in the infrarenal IVC, the contralateral renal vein, and the upper part above the thrombus. And the other imaging that we can use ultrasound to control the contralateral, the collateral vessels. At some time, we have some lumbar vein that need to be dissected, identified, and then especially in fatty patient, it could be not so easy to identify. You use the ultrasound, it can helpful to predict where the ostomy is and to dissect better and prevent major bleeding.
Do you have any other remarks you wanted to talk about after you talk?
If maybe we can discuss a little bit more about the venous branches thrombosis, because we know that T3A disease means invasion of the vena cava, but sometimes you could have also small renal masses with thrombus in the vein, and how to manage this patient could be
Like when you are doing a
charged.
partial.
Yeah, when you do a partial, sometimes you don't have, you don't see, or it's not predict the presence of thrombosis at the CT scan, and you face in a partial nephrectomy and see a little thrombus inside the venous.
Well,
It's questionable to perform, to go ahead with a partial or convert to radial nephrectomy.
yeah.
There are some words that say that the stage T3A disease still have a good prognosis, 80 years % recurrence-free survival. So in my opinion, if you have a small thrombus inside the venous and you can resect completely with no residual, you can go ahead with a partial.
It's safe. Right?
Yeah, it's safe. Could be safe. Yeah.
Yeah, it is. It's a fair option. Well, thank you very much for your comments, and we appreciate it a lot. And hope the audience really enjoyed and they learned something from today's talk.
Thank you very much for your consideration.
Thank you for listening to EAU podcasts. To keep up to date with kidney cancer developments, visit our educational platform, UROONCO Kidney Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.